Hi, it's Dr. Centeno, and welcome to my show today. You've got the power. Got a really interesting topic today, kind of an update. We're going to be focusing on how the diagnosis for craniocervical instability gets made, or at least how we do it. Now, there's certainly other ways to get to this diagnosis, so I'm just going to share the way we get there. We're pretty thorough in what we look at. So again, as usual, I'll start with that topic. I'll give a short presentation. Then I'll go to questions and answers once I'm done with all of that. So let's go, and I will share the screen. And again, today's topic is how a diagnosis of craniocervical instability gets made. And from there, we'll then go to Q&A. You can either ask questions about that topic or any other topic at all. So again, I see some people are just joining us now. Focus today is on how a diagnosis of craniocervical instability gets made, all the different parts and pieces of that. And we'll do that first and then go to Q&A. You can ask questions about that or anything else at all. So let me go and share my screen here. And we've got someone watching to make sure all of this goes correctly. Okay, so it looks like it's shared. We're going to go to the presentation now and get that started. And let's get a marker here. So how do we make a CCI diagnosis? Now, I've talked about this before, so this is an update, but I'm going to go into more detail than I think I ever have gone into on this topic. So what are the basic elements of a craniocervical instability or CCI diagnosis? Now, these are our basic elements. I think you'll find that some of the surgeons might do this a little differently. And I'm pretty sure we're probably up there in being the most thorough in our requirements to get to this type of diagnosis. So we're going to look at a bunch of different things here. And these are all like pieces of a puzzle, right? Diagnosis in medicine in general is like a piece or like pieces of a puzzle. You put the pieces down and they fit together and they make a picture. And if that picture looks like CCI, then more likely than not, you're dealing with a patient who has symptomatic craniocervical instability. If it looks like something else, then your certainty about the diagnosis goes down. Doesn't mean they may not have craniocervical instability causing symptoms. It just means that you're less certain that they do. So the components we'll look at today are history, and then symptoms, and then the imaging component, how we use that, response to treatment, the exam, and then other causes being ruled out. Because one of the problems with craniocervical instability is there's a lot of overlap between the symptoms of CCI and other types of problems that might share similar symptoms. So in history, we're going to break it into two parts. The first part is, how did the patient get craniocervical instability or CCI? And for high likelihood, again, you're going to see me create these two categories here as we go through these things. Higher likelihood and lower likelihood doesn't mean that these people might not have CCI. It just means there's a bigger question about whether they do. And this is the one we'd like to see because this is the one that's the most clear. So obviously some sort of trauma to the head or neck that can cause CCI. And another one would be EDS or stretchy ligaments. Lower likelihood are going to be these things down here: Lyme, mold, COVID. Now, doesn't mean that Lyme might not cause something like this, but it does mean that we don't have nearly as much research. In fact, we've got none on that topic. Or mold or COVID. COVID, we've got even less, right? Because that's a relatively new phenomenon. And we're still trying to figure out which end is up on COVID-19 and long COVID. as a diagnosis. So if someone walks in, that means, and they say, well, I was in a car crash and 3 weeks later I started getting severe headaches and dizziness. Well, okay, that's a nice little connection there. But if someone says I got COVID-19 and 6 months later I started to get these symptoms, very hard to draw that connection and have the information that draws those two pieces together at this point in time. Now, the second part of history is temporal association between the event and the symptoms. So what does that mean? That means that there's something that happened, and then shortly after that, the symptoms began. So for high likelihood category here, we're going to see a clear line between the event and the symptoms and not much time. So again, going back to the example I just gave, I got into a car crash. The week later, I started getting headaches and dizziness. That's a nice temporal association between those two. Lower likelihood might be I got in a car crash 20 years ago, and I just recently started to have these symptoms. Now, the car crash may have caused problems that led to these symptoms, but as you can see, there's less of a clear relationship there between those two. And if we go to symptoms, the symptoms themselves matter. And this is from 101 confirmed CCI patients where we asked them their symptoms. And the bigger the word, the more likely they were to report that symptom. So you can see here that the first tier would be things like headache and dizziness, lightheadedness. Those are the most common things that CCI patients report. Then we get down to the next size of these words or the next frequency, and we're in the sort of the second tier symptoms, numbness and tingling and neck pain. Then we get into the third tier symptoms. And so now we're going to be at things like less commonly reported shoulder pain, cracking, which is crepitus. So that's going to be a third tier symptom. GI symptoms, a third tier symptom. Lumbar pain, a third tier symptom. Fatigue, a third tier symptom. Brain fog, a third tier symptom, and on and on and on and on. Obviously, we could go through this quite a bit, but you can see that there's some cluster of things that are very common and that point in the direction of being more unique to craniocervical instability. And then if we look at all the symptoms on this screen right now, not going to be so unique, right? Low back pain. What else causes low back pain? Well, a herniated disc in the low back could cause back pain. A bad facet joint in the back can cause back pain. POTS. What else causes POTS? Cardiac problems can cause POTS-like symptoms, etc. Blurry vision. What else causes blurry vision? Tons and tons of things. As you can see, we're trying to use symptoms here that are more unique to things like craniocervical instability. Doesn't mean that you have to have those symptoms to have craniocervical instability. It just means you get an extra check mark if you do. And so again, the main symptoms are things that are shared by most CCI patients and more unique to that diagnosis. So we talked there about someone with headache and dizziness in a context where the other causes have been ruled out. And then we get to, top 3 symptoms. You'll probably hear me if you do a phone review with me or a telemedicine review, that I'm constantly asking the patients, what are your top 3 symptoms? And then, it's not that people with these things like this, fatigue, GI problems, and POTS don't have CCI. It just means that if you give me those 3 top symptoms, it's going to be a little bit more confusing and a little harder to get to a CCI diagnosis. Imaging. So I've kind of put this into high likelihood and lower likelihood. So these are the things that we most commonly see. So as I've said before, if you had to pick one imaging test that's the most likely to get to a CCI diagnosis if it's present, meaning that that has the lowest rate of catching it if it's there, being a true positive. That's going to be digital motion X-ray. Then we get into the most common finding would be C1, C2 overhang over 3 millimeters. And then we've got atlentodental interspace inflection over 2 millimeters. And that can either be on DMX or just on routine flexion extension X-rays. Then we've got grab oaks, which is something that we can see on MRI. And that's a static grab oaks over 9. And then we can see an increase in grab oaks of more than 3 millimeters on a movement-based MRI. Then lower likelihood, an MRI showing changes in signal in the ligaments in the upper neck. But I just made a diagnosis like that today, right? Doesn't mean I can't get there. It just means that we're going to have to see some stuff that looks really unique. So this was a patient who had a pretty unique appearing transverse ligament. I was able to put together the other parts and pieces and feel pretty comfortable that we had CCI. And then we've got what I call the structural neurosurgical metrics without motion, things like BAI and BDI, which for me are going to be less convincing. And the reason why we're focused here on DMX is that DMX has a study that was done in this patient population, the kind of folks we're seeing. So the research right now is the best on DMX because that research is on the patient population we're talking about. If we go to other types of things, like some of these structural neurosurgical measurements like BDI or BAI, and some of the other things that are used, Powers ratio, etc., that research is not on this patient population, but on a severely injured population that requires emergency surgery. So that's the problem with those metrics, is that they come from surgical papers where people basically got injuries or their head was falling off and they needed emergent surgery that day or the next day to keep them alive. Whereas DMX is research in the chronic pain or the chronic problem population. And that's one of the big problems I have with the traditional neurosurgical measurements is if you want to use those, great, but you're going to have to do research studies on this patient population, folks with chronic problems, not rely on studies that were done in people walking to the ER after a severe hangman's type fracture injury. And that's the disconnect there with the neurosurgical measurements in my book. And then imaging, likelihood of finding a CCI diagnosis. I think we've just talked about this. DMX is usually the most likely for us, then movement-based MRI, then static upper cervical MRI, then a regular cervical MRI. Now, it doesn't mean I can't find it on a regular cervical MRI. It just means if we take 10 patients, right, who all have CCI, and we're run all 4 of these studies, then most of them, let's say 7 of them, I'm going to find CCI on a DMX. Sorry, it should be over there. And on a movement-based MRI, maybe we'll be able to identify 4 of them, and on a static MRI, 2 of them, and a regular cervical MRI, 1 of them. So again, for my money, we want to go with the test that's most likely to show it. And again, we talked about that DMX is the only one that looks at this patient population, people with chronic problems versus those with their heads falling off walking into an emergency room, which is where the neurosurgical measurements come from. Then we talked about movement-based MRI. Biggest issue there is we don't have much research there. But it does tend to work pretty well in showing CCI in HEDS patients. And then we have static upper cervical MRI. That's a specific type of MRI where a head coil is used. And we do have some early research by Crockiness that's helpful, but kind of inconclusive because that research went back and forth in the peer-reviewed literature. And then regular cervical MRI, sometimes we can see a high grab oaks, which may be very helpful. So that's kind of how that works. And then we've got response to treatment. So high likelihood would be things like active physical therapy makes things worse, cervical collar helps, upper cervical chiro helps. Lower likelihood is something like I took a bunch of antibiotics for my Lyme and I felt a lot better. Now, it doesn't mean that that person doesn't have CCI. It just means that all things being equal, if I get this, I am more comfortable about my CCI diagnosis than with the treating Lyme thing. And then we've got physical exam, and that is that localizes to the upper neck. Now, that's different than the 5-minute quick, can you feel this? I'm going to bang on your tendons, and I'm going to turn your head a little bit exam. There, we're talking more like 20 to 30 minutes of hands-on exam. And in addition to that, spending almost an hour in total getting to know that patient. So it's a little bit different than other exams. And then the low likelihood thing is there isn't any tenderness or other things we're looking for related to the upper cervical spine. And we can't really point to that spot based on exam. So that's going to be lower likelihood of having CCI. And then other causes, and this is simply just making sure that you do good medicine, right? You want to make sure that if you've got dizziness, for example, it's not coming from the inner ear, and that's a VNG test. If you've got neurologic symptoms, then we've ruled out MS with something simple like a brain MRI. And then lower likelihood and a concern is always when I see a patient that has none of these things worked up, and we've got to ask that they get them worked up, or we've got to get basic imaging on that person because it's never been done. So here's an example of highly likely CCI history. Let's say they got into a car crash and the symptoms are headache, neck pain, dizziness, imbalance. And the DMX shows 4 millimeters of overhang. And when they wear a collar, it's great, but they don't want to be in a collar all the time. The exam localizes to the upper neck, and then they've had a bunch of things ruling out other causes for these symptoms. Less likely, CCI, I had COVID-19. Now they tell me I've got long COVID. And 6 months after that, I started to get these types of issues. Symptoms are POTS, GI, brain fog. Again, doesn't mean this person doesn't have CCI. It just means that it's a lot harder now to get to that diagnosis. Imaging, there's not much on imaging. Response to treatment, that doesn't fit. The exam, the neck isn't implicated at all. And there's been no workup of other causes for these symptoms. So in summary, there are components that make up a CCI diagnosis. It's kind of like a big puzzle. You want to put all those puzzle pieces together so that you feel comfortable as a doctor that you're doing the right thing for the patient. And that's what it really comes down to. Because listen, I could obviously, if we're talking financially, I could make a lot more money if I just said everyone who thinks they have CCI has CCI. I don't do it that way. My job is to try to get to as certain a diagnosis as I can get to before offering care that might help that diagnosis. Doesn't mean I'm going to always be right. Doesn't mean the patient's always going to respond. It's just upping the odds of those responses. And obviously being a responsible doctor, because if you allow patients or very small pieces of information to drive diagnoses, then that doesn't help anybody. You end up with a lot of people who are very angry in the end because they didn't get the right diagnosis. So diagnostic accuracy is not 100%, but the goal is to get it as good as we can get it. So let me stop the sharing here, and then I will go and answer some questions here. Okay, so let's start with duct P. Have you seen an abnormal CXA angle return to normal after posterior PRP or PICL procedure? Abnormal CXA angle return to normal. Realize I'm not too concerned about abnormal CXA, but let's talk about that a little bit. And for those of you that may not know what we're talking about. Okay, let me share this here. Okay, so clivoaxial angle is the angle up front here as defined by this yellow line. And it indicates that the skull is either falling forward this way if the angle is low, or falling back that way if the angle is high. Now, the absolute angle is not that concerning because most of these are within a range. But I think the bigger issue is that we may see big changes in that angle between flexion and extension that are abnormal. And again, pointing towards instability, meaning excessive motion, rather than the angle of the dangle being too much or too little. So it's a good angle to have, and it's another piece of information about what might be wrong, but by itself, it doesn't mean a lot unless it's associated with instability. So the goal wouldn't be to change the angle. The goal would be to reduce the movement at that angle, which is to get rid of the instability. On patients that live near your clinic, how do you decide between prolotherapy or PRP for chronic ligament laxity? So either prolotherapy or PRP, a lot of that's going to be how much ligament laxity we have. So if we've got just a mildly lax ligament, then we'll just hit it with a little prolo. Usually while we're just in the office, if that can be done, sometimes it can't be. We'll have to obviously take it to a procedure room. If there's more instability than PRP, and if there's even more instability than bone marrow concentrate. So that's how we make that decision. Doc P, what is thought on using needling technique when doing prolo? I read a case study where a patient tried prolo without needling with prolo resolved his SC joint habitual dislocations. Not sure you can put much into a case study. Dry needling, I think, is what you're talking about. So dry needling is normally without prolo. So I'm not sure what you mean by needling with prolo, meaning that prolotherapy by itself is a technique where you inject lots of different spots within the ligament. And so maybe that's what you mean by needling in quotes. So not quite sure of that question. Already did that one. Regenix submitted advanced by Oleg. Actually, since my issue started, I have HEDS, but not super hypermobile yet. Lots of muscle tension. I've noticed points that line up right along those meridians, i.e. along the side of my leg, to my hip, and my arm, and out to my shoulder and neck, where tension seems to be worse and a little bit of relief in higher lower areas if pressed on, i.e. even pressing part of the calf and shin on outer leg against a corner will release in hip or upper back. So I wouldn't call those meridians. That's kind of an acupuncture term. I think probably better to call those, so for instance, an S1 nerve that comes from the back, that goes to parts of the hip, that goes to the calf. Certainly, it's possible to change the input along the S1 nerve, and that can release things in the hip. So I think that's the better way to think about it, because once we start calling it an acupuncture meridian, we're kind of off into much harder to research land. But once we described more accurately as a spinal nerve problem, that gets a lot easier to understand. Randy Miller, I see you need to get up there soon to check this for me. Sure, Randy. It's been advanced by Oleg regarding muscle atrophy interpretation from MRIs. Can you or Dr. S check mine out to see if I have it? I don't have a bobblehead as one of my CCI symptoms. Does that mean I don't have atrophy? I do have lots of back, neck aches, pops, cracks, and neuro symptoms, though. Sure, happy to check your MRI to see if it's got atrophy. Oleg, just reach out to my email address. I think Carol, who monitors our Facebook, has that. And if you want to send that to me, I'm happy to take a quick look at it. Regenics have been advanced by Oleg. Last question. Since at least my early 20s, I have a spot, maybe a couple of inches in diameter, on my right upper inner thigh, right below the groin area, where the skin gets kind of numb superficially. I only notice if I touch the area while laying down, but otherwise doesn't bother me. What could that be linked to? Yeah, so let's look at dermatomes. I don't believe that follows a dermatomal path, but it's possible. So dermatomes are the areas of the skin that are innervated by the spinal nerves. Now, regrettably, these are little pictures for you guys to see. So maybe I'll copy one and put it in a presentation so we can make it bigger here. So let me do that here. Well, that didn't work. That one's not so pretty. Let me find a prettier one. Let's see here. Okay, let's try this one. Okay, let me share that now. So I think you guys can see that bigger. I'll make it even bigger than that. So these are dermatomes. Dermatomes are where the spinal nerves innervate on the skin. And it looks like, assuming it's in this pattern of L2, looks like it certainly could be an L2 or an L3 nerve, depending on if it's higher up on the inner thigh and includes the front versus lower down. So that's one thing that's possible, is an L2 or L3 spinal nerve coming from your back. Now, another thing that's possible is it's a local nerve there that may also be having issues. But the first thing I'd kind of rule out is it's whether or not it's an L2 or L3 spinal nerve. Oleg, follow-up question to my example of massaging hip causing neck release pop. Is it fascia overlapping affecting other regions? Is this what acupuncture, shiatsu, meridians are based on? I know you recommended a book, but due to CCI, it's been difficulty to study those now. What causes my fascia to be in such a state? Is it a body trying to stabilize joints through muscle? Would myofascial release then be potentially bad for me? You know, Oleg, that's when I'd have to do a hands-on physical exam on in order to really feel certain that I was giving you the right answer. Regenics, Harry Winston, I found being in an automobile is incredibly difficult for me. I think it's maybe because when I'm walking, I can brace myself, but in a car, I have no idea what forces are coming. Yeah, I think you're 100% right, Harry. That's what I've seen a lot, is that many of our CCI patients have a hard time being in cars because you don't really know where all the forces are coming from. If you're the driver, you're a little bit more clued in, but even then you could go over something that jostles you and that you didn't see. And obviously it's much, much worse if you are a passenger. So I think that's right. Megan May, I understand injections can heal damage, but what about tightening, overstretching vertically from a traction injury like the nuchal and ALL, PLL is severely overstretched? I understand, but about tightening, overstretching vertically. So I'm not quite sure what you mean. I think what you mean is that you believe you have a traction injury that injured the nuchal, anterior longitudinal, and posterior longitudinal ligaments. So if the question is, can those ligaments be treated? The answer is yes. Liam, is the period of ligament swelling inflammation immediately following the PICL ever a concern for creating long-term symptom flare-up? If so, what patient type would that be? The fragile eggs. Yeah, Liam, so for all of that stuff, we're talking about a bell curve. So let's look at the bell curve here, just so that everyone understands what it is I mean when I say bell curve. So let's get to classic bell curve here. So a classic bell curve, you may remember from when you were in high school or something, or in college, that a classic bell curve looks something like this, where you've got most people that live in the middle, and then you've got people out on either tail. And so when it comes to, well, doesn't want to share that. Let me go ahead and reshare that, guys. Sorry about that. Well, maybe let's do my entire screen and then put it up. So classic bell curve, again, is where you have most people in the middle of the bell curve, and then you've got people on either end. So who's going to be on either end here? Well, we've got people who we inject, and they don't even know we injected them. And then we've got people in the middle where we're talking 3 to 7 days of flare-up, and then people on the other end where we're talking about weeks of flare-up or months of flare-up. And the percentage of those people roughly follow this kind of thing. Now, who are the people who have longer term flare-ups? Those are definitely going to be those patients who are what I have called fragile eggs, or those who have central sensitization. So their nerves are overly sensitive, and those people generally know who they are, right? If they get a massage, they'll be set back sometimes days or weeks, or if they've had any prior neck injections that took a very long time to recover, or if they jostle themselves the wrong way, we're talking about being knocked out for weeks or months. So those are the kinds of things we're talking about. But again, that bell curve is something good to keep in mind because most of those patients are in between. Deanna, my first x-ray was normal ADI, but I did not go into full range of motion as I almost fainted from flexion. Repeat x-ray shows overhang, and I'm sure if ADI is accurate as x-ray enough, supine MRI and CT were normal, trying to avoid DMX radiation as breast cancer risk. Well, I'd be concerned about breast cancer risks in DMX, meaning that DMX is going to have the same amount of radiation as if you were a frequent flyer for a month or something. So I'm not sure that I'd have that concern when it comes to getting into full range of motion. You may need something like some Valium. So sometimes we'll do that and give patient medications like oral Valium where they'll be able to move more. And obviously, if you can't do it, you can't do it. And that's not uncommon either. We have patients who just can't tolerate getting into flexion because it causes things like feeling like they're going to pass out. Anya, hydroxynteno or posterior ligaments injected with contrast or just under fluoroscopy? Thank you. Posterior ligaments, depends on what we're injecting. So posterior ligaments are injected either under x-ray, and that might be with or without contrast, depending on where we're injecting, what we're trying to inject, and or under ultrasound. So it all depends which structures we're talking about. So let's say we're talking about the PAOM, which is very deep. That one will be done with X-ray and contrast to make sure we're at the right depth level to do that. Or the ventridural ligament, which can be tricky sometimes. That's a contrast one. But if we're talking about a C5 supraspinous ligament, that would be done usually under ultrasound, but could also be done under fluoro as well. Steve, will the DMX reveal pinched vertebral artery? No, not usually. You're not seeing any arteries at all on DMX. Now, you certainly may see something that looks like there's enough motion where you'd be concerned about the vertebral artery being compressed, and then you might want to study that if that was something that was a concern. But that would be a different set of imaging. Can idiopathic hyperinsomnia after a motor vehicle collision be caused by CCI? Usually not. That wouldn't be a common CCI complaint. Not saying it can't be CCI, it's just not at all common. Anya, what are situations where the lamina, the bone itself, is injected? Anya, we generally don't inject the lamina bone. I've certainly injected vertebral body bones, and we've injected, for instance, into things like pedicle fractures, where you've got spondylolisthesis happening, especially in a young patient where the spondylolisthesis is acute. But as far as injecting into the lamina bone, meaning inside the bone, that's not something we've done. It would be a little dangerous to do inside a lamina bone just because it's fairly thin, and the difference between being in the bone and going through and through the bone into the spinal canal is not that much. Duck, if a patient has a very minor 1 millimeter subluxation of C1 in typical flexion extension reviews, but no overhang and lateral flexion, can be treated with posterior PRP. I'm not quite sure what you mean by subluxation of C1. Do you mean an increased atlantodental interspace? Do you mean that the vertebra is shifting 1 millimeters? Not quite sure what you mean there, but if we're talking about, for instance, things that are showing up in flexion, then posterior PRP may be very effective as long as the internal ligaments, things like transverse ligament, aren't involved. So I need to know a little more there. Duck P, is it okay to space PRP treatments every 3 months? Yeah, it depends on what it is you're injecting, but I think in general that's okay. One of the lessons we learned during the pandemic is that since we have patients that, depending on where they were, had a harder time coming in, we realized that in our CCI population, we had about half of our patients where it didn't seem to matter that they had a delay. They kind of left off where they next began. But the other half of our patients did regress. And what it showed me was that for about half of our patients, we've got to get them on a regular schedule for injection so that they don't regress and so that they can actually make forward motion. So that was an interesting one. Anya, what does PRP do for facet arthritis and vertebral disc degeneration? Does it help restore the cartilage or only helps with pain? I know that stem cells help the cartilage regenerate. Not really, Anya. I think you've been scammed a little bit there. Stem cells are not going to regenerate cartilage in a degenerated facet joint. That's likely not going to happen. So that one's not really occurring, nor will stem cells reliably regenerate in degenerated discs. Now, we have seen a few examples. Remember, I was the first person on the face of the earth, on the planet, to inject stem cells into a disc or stem cells into a facet joint. There's no one that did it even 5 years within the first time I did it. So I've got the most clinical experience on earth with these particular things. And so about 1 in 5 times, if you use the right stuff, you can see an intervertebral disc seem to gain the ability to hold back or hold on to water. but that's not a really degenerated disc. That's just a dark disc. You don't see them go the other way and replump and gain height. You can get rid of a disc bulge if you use the right mixture in the right place in the disc. But again, the disc, that's only with a disc that has good disc height to begin with. And as far as facet arthritis, we're generally not seeing facets regain cartilage that are severely degenerated. Now, it's possible that if you just have a small cartilage tear from something like a traumatic accident, that may heal over given the right stuff being injected, but not a severely degenerated facet going back to growing cartilage. Dr. Centeno, you've suggested we try AO NUCA before PICL or PRP. Had 2 NUCAs in Canada, and they refused to treat someone like me with ALO overhang. I think you found an AO who will see me. My consult is with you soon. Should hold off on AO treatment until I talk to you. Hope you return to school and feel time pressures. You know, usually what I mean by that recommendation is, AO chiropractic, establishing a good relationship, NUCA chiropractic with somebody, and trying to see if it helps is a good idea. Now, if you've got a lot of instability, in general, that's not going to be a long-term solution, but having a good relationship with one of those providers can be key for recovery. I'll give you an example. So we've got two great local AO providers that we use. And after PICL, since patients are getting moved around, they're on anesthesia, some of them will go out and they'll see one of those providers and feel much, much better after the procedure. Now, those are generally patients who have had a relationship with somebody and they kind of know AO helps them. So it's easier for us to make that recommendation, go see Dr. X to go try to get that treated while you're still here in town. So that's really the rationale for that. Now, doesn't mean we won't treat you if you've not seen an AO, especially if you've got very clear evidence of instability, because in general, we're not expecting AO to solve that instability problem. Liam, for a patient like me who works full-time and would be traveling domestically, is there a recommended day of the week to do PICL on? Trying to figure out the logistics and flight arrangements for a trip to Centeno-Schultz Clinic for the PICL. I would be taking my mom to help me out. Is this something I should reach out to Jennifer for? Sure. Yeah, Liam. Generally, what happens on my schedule is I do PICL procedures on Tuesdays and Wednesdays. Dr. Schultz does them on Thursdays. So that gives you some idea there. As far as the ideal time of week, a lot of that obviously depends on your work pressures and when you got to be back to work, etc. So, for example, if you were trying to get back to work that following Monday, then you'd want to do it earlier in the week to give yourself more recovery time. So those are the kinds of things I would be thinking about as far as choosing a day of the week, meaning, giving myself a little bit more recovery time if I had to get back to work, or if I didn't have to get back to work, maybe a little bit more recovery time before I had other responsibilities happening on Monday, that kind of thing. Deanna, I get severe restless legs at night after my CCI accident, in addition to my insomnia from pain in my skull. What causes restless legs? Diana, no one knows. We don't have that many restless leg patients. I've got a few. One I can think of off the top of my head does well when we calm down her lumbar nerves. And that's usually using a platelet lysate injection epidural around those nerves. But as far as what causes restless legs, no one's 100% sure. I think it's personally related to how some people respond to nerve irritation, like my patient, where if we calm down the spinal nerves in her back at L5 and S1 with a platelet lysate epidural, she's good. Or at least it's more controllable. Let's put it that way. Duck P, how strong is Amber PRP and proper concentrations compared to dextrose prolotherapy? Here's what I tell patients with that. And I always sort of talk about a standard model. A standard model to talk about would be, let's say, SI joint instability in women. And that's a good one because, treated it lots and lots of times with prolotherapy, with PRP, with bone marrow, and I can tell you how that compares. So for instance, for the average woman for prolotherapy, we're probably talking about 6 to 8 visits for SI joint instability. Less for men, but that's kind of what it is for women. If we switch that person out to PRP, we've kind of halved that. So now we're in the 3 to 4 visit land. And if we do bone marrow, we're kind of half of that again, or even less, 1 to 2 visits. So that's how those things generally compare. Now, because of that, and because I'm not into bringing a patient back a dozen times, therefore, I won't recommend prolotherapy very often anymore for SI joint instability in women, because it seems silly to me to force the patient to come back 6 to 8 times to keep me busy when I can get it done in 1, or I can get it done in 3. So we'll have that discussion. Now, I know there are clinics out there that treat a dozen times with prolotherapy. And that's all well and good, but I just don't believe in doing that when you've got technologies that can get it done quicker, because patients are real people, right? They got responsibilities. They got, kids to take care of. They got jobs to go to. They've got friends to see, et cetera, et cetera. So if I bring someone back a dozen times, when I know I could get it done in 2 or 3 times by just changing the technology, that's putting a pretty big burden on the patient. And it also kind of would really, make it very hard to get in to see a provider, because what should be 3 visits now turns into 12, that kind of stuff. Duck, what is your thought on C1-C2 fusions being performed on symptomatic Down syndrome patients? My thought would be the same as it would be for any of the things we're talking about. We should always try the least invasive thing that has a shot at working. So same thing here. We would be looking at something like a PICL procedure to see if we could get it done without the need for surgery. And if that can't be done, then a C1-C2 fusion may be reasonable. But starting with a C1-C2 fusion doesn't make a lot of sense if something less invasive has a significant shot at working. So same thing as anything else we're discussing. Deanna, can you treat SI joint pain during PRP or PICL procedure? We can, and we frequently do, Diana, but just remember that caveat that I discussed in previous shows, and that is that I always get concerned trying not to overload the patient, especially if that patient is very procedure sensitive. So for example, 2 different patients, right? One patient walks in, had a couple of procedures before. I asked them, how did you recover? Oh, not a problem, sore for a couple of days. Sure, that patient will definitely treat the SI joint during a PICL procedure. Now let's go the other end of that spectrum. How'd you recover from past procedures? Oh, some guy tried to do prolotherapy in my neck. Took me 2 months to recover. We're not doing SI joint in that patient with a PICL procedure, because I don't want to throw them over the edge. They're already going to have a hard time recovering from PICL, and I don't want to create a scenario where there's a super long-term flare-up and they're super long-term disabled, because the more time they spend in bed, the weaker they get, the less they're able to protect their joints, etc. So that's how we view that. Zachariah, hi, Dr. C. Would you be able to show an example of ligament damage on a supine MRI? Yeah, I just saw one. I'm going to have to log back into our system to pull that up, but it might still be on my desktop. Let me see. The answer is I'm going to try real hard to see if I can find that for you, but I got to log in, and that's going to take up some bandwidth. So hopefully it doesn't mess up this connection. But I'll log into the office computer and see if I can pull something down. Okay, let's see what we got. So I'm just going to check my, oh, here it is. Good. Sitting right there. So I'm going to have to get rid of this person's name because I don't want to expose that. That's not fair to the person, and that's a HIPAA violation. So we don't want to do that. But I'm going to try to get this on a slide so I can show it to you guys. So this is a patient who had a pretty good upper cervical MRI, and we didn't get a chance to see the 3D reconstruct of the alar ligament because the patient was unable to get that done, or at least that file didn't work. But I did see a transverse ligament injury. So this would be a good one to show you. So this is a supine MRI. It's a specialized MRI where a head coil is used instead of a neck coil using a specific protocol developed by Crockinus. And now I can share that. I do not know why that is not showing up. Let me, well, I'll do the entire screen again. That'll work. Okay, so this patient is a patient I saw today. We were doing a telemedicine. And again, as I've said, we can sometimes find ligament injuries on a static MRI. Now, this is a better static MRI because this is a static MRI that's designed to look at the upper cervical ligaments. And there's a couple things happening on here, just on this one slide. So let me go ahead and show this and then get a pen. So this is the dens here. That's C2. And this is the atlas, or C1. And this is the transverse ligament here, or also called the transverse band of the cruciate ligament. And you can see that all of that looks kind of uniformly dark. But then we get over to the right part of the screen here, and we see this white glob in the middle of it where it attaches to a little process that comes off of the lateral wall of C1. So that's a transverse ligament injury all day long. Now, she also had an alar ligament injury I didn't get a chance to look at. And then there was some funny stuff going on. Her clivoaxial angle here was high. I think if I recall, it was like 157. So 150 to 155 there. And by itself, that doesn't mean a lot. But when you look at some of these ligaments here, like the AAOM, they don't fully connect. So probably an injury to these ligaments up here causing the skull to move backwards like that, which is why we have the high clivoaxial angle, or CXA. And then we see this transverse injury here, transverse ligament injury as well. So that's what that looks like on a static high upper cervical specific MRI. And I'm going to stop my sharing there. Keep those. And I'm going to actually close down the connection to my office because that's taking up bandwidth. Okay, so that's what that looks like, Zach. Megan, are you getting a lot of patients reporting positive results? Sure, let's see, this last 2 weeks. So what we do is we'll check back with the person around 3 to 4 months. In the last 2 weeks, I'm just going off the top of my head, I think we probably reached out to about 10 patients. We had 1 no response. We had the rest of them responded in varying degrees. We had about maybe 2 of those which had smaller responses. Of the remaining 7, let's say 5 with really solid, pretty substantial responses, maybe even all 7 of them, if I think about it. So basically that would be things like, I couldn't clean the house before, now I can. I couldn't go for a walk before, now I'm walking a mile, that kind of stuff. So yeah, now that's probably not representative of the total population. I always tell patients in the total population, I think we're doing well in about 7 and 10 of our patients, or well enough where we're getting them enough function where they're not moving on to things like upper cervical fusion. But that still leaves about 3 that do. But that's an example of the last 2 weeks or so of patients we've reached out to, asked them to answer questions and follow back up with us to see how they're doing. And I also think now that having the dual x-rays is making a tremendous difference in placement. So we're probably going to see some of the PICL results even go up from here, simply because, you know, we can get a lot more accurate with placement with those dual C-arms. And, you know, dual C-arms are almost never used in medicine. There was actually a machine that's called the Whale that has dual C-arms, and they had a hard time selling it. So we actually had to buy 2 C-arms. Lindsay, at what point after a PRP can you say it's failed if symptoms don't improve at all? Lindsay, I'd say you probably want to wait a good 4 to 8 weeks. If you're not seeing much at that point, then you're probably not going to see much going forward. Anya, I wanted to ask, I have instability in all spinal regions, which causes severe thoracic pain, probably in facet joints. It gets worse with movement, even walking. What hurts exactly? I'm not sure how to answer that one with that amount of information. Certainly instability can lead to things like, just as you discussed, facet joints getting irritated or becoming arthritic. That can also lead to pain in the ribs and the rib facet where the ribs attach, just staying in the thoracic spine now. It can cause irritation of spinal nerves, which can cause zingers that kind of go around, or numb areas in segments of the thoracic spine. So all of that can happen with instability. Anya, is it facet capsules getting compressed under pressure because of instability, or nerves or muscles? I don't understand what happens exactly. I assume facet joints sublux. Yeah, I mean, Anya, it's all of the above, right? So if you've got a joint, which is made up of 2 halves, and it's unstable, that joint's moving around more than it should, and that causes inflammation within the joint. And then eventually, if it stays like that for enough time, the cartilage goes away, and that causes arthritis. Now, realize that there's a lot more going on than that. There's a capsule involved, and the capsule can get torn up, and that cannot be happy. Then you've got muscles that attach to the joint with tendons, and those are getting beat up as well. And then near that facet joint, we have a spinal nerve that can get irritated, etc. So any or all of the above is the answer, but it's one of the reasons why. For example, let me give you guys an experiment, which I think will tell you a lot about instability. So if I'm a researcher in a university and I'm working with, let's say, rabbits. Rabbits are my animal model. And I want to create knee arthritis in a rabbit. How do I do it, right? In order to do an experiment on knee arthritis in rabbits, they have to have arthritis. Well, rabbits don't really develop arthritis. So rabbits just with age don't get arthritis. They don't live long enough to get arthritis. But I can make that rabbit have knee arthritis by cutting the key ligaments like the ACL or the MCL or the ACL in the rabbit, and let that rabbit run around and do its normal stuff. That rabbit will develop arthritis in that knee fairly quickly. Now I've got arthritis in my experimental model that I can use to treat. So you see how critical those ligaments are in protecting the joint and preventing arthritis. Anya, thank you. If it doesn't generate regenerative cartilage, exactly when PRP or stem cells are injecting discs or facets. Yeah, Anya, so the goal is, if it's a severely degenerated joint, to reduce the swelling and improve the balance of regeneration versus degeneration, or what we call a catabolic cascade. A catabolic cascade is that the fact that the joint has arthritis causes nasty chemicals. Those nasty chemicals then cause more arthritis. So the goal is to block that process. In addition, we want to reduce instability that could be further harming the joint. So that's all those ligament things that we were just talking about. And or there may be a disc bulge that's pressing on something. So we want to repair those annular fibers in order to reduce the size of that disc bulge. Or there may be in a disc what's called an HIZ, or a painful tear, and we want to help that painful tear heal. Now, we're not going to make that person a new disc, but we can do things like get rid of HIZs or painful tears in discs using things like PRP injections, specific types, high-dose leukocyte-rich, or bone marrow concentrate. Megan, do you know anything about fasting for long periods and regeneration? Yeah, there's some interesting research out there on FMD, fasting mimicking diets. And there's one out there called Prolon, which was made by, I think, the guys at UCLA or USC. Regrettably, I don't live in California, so I forget, when I hear about one, I can't say it sticks in my head. But let me see if I can share that with you. So I don't work with this company. I don't get any money from this company. But this is a company called Prolon. They make a fasting mimicking diet. You get this little pack and you eat what's in the pack, which is what it looks like down here. And that type of calorie restriction has all sorts of benefits, not the least of which can be an improvement in stem cell activity within the body. Now, is it necessary to do that or just eat clean and try to lose some weight? You'll probably do pretty well if you just eat clean and lose some weight. But at the same time, if you wanted to use a fasting approach, this is probably the easiest way to go because it comes in a little box. You know what you're supposed to eat. You don't have to mess with counting calories, etc. And this was made by some university scientists that were very much into doing research on fasting mimicking diets. Again, I've got no relationship with these guys. I have bought these myself. I didn't ever get any for free. They're not cheap, but they are it's a really good product if you're thinking about doing something like that. Deanna, is P2G a safe, effective Prolo solution? I was getting dextrose, then my doctor switched to this from a posterior Prolo below C2. Yeah, the biggest concern with P2G and the reason why we don't use it is it's pretty toxic on nerves. So if you were to get the Prolo solution, a regular Prolo solution close to a nerve at the normal Prolo percentage, 10 to 15%, you're probably going to cause some injury to that nerve. But if you use P2G, you're definitely going to cause severe injury to that nerve. So if you were using something like P2G or any Prolo solution, that's why you've got to use pretty specific guidance to make sure you're nowhere near any nerves when you're injecting. And again, 10 to 15% Prolo is going to do some nerve damage, maybe not a ton, depending on which nerve you are at. But P2G will do a lot more. So that would be my concern about using P2G, especially in a blind or palpation guided Prolo solution. How many patients get worse or additional neurologic symptoms from upper facet PRP for trauma-induced CCI? Upper facet PRP. I haven't seen a lot get worse from upper facet PRP. So that one is kind of not a thing that I have seen enough to know what the percentage is. A lot of that would depend, though, on what it is we're doing there, meaning that if you're kind of blindly sticking a needle with just a fluoroscope in that general vicinity or trying to use ultrasound to get into those joints, you may do more damage. But as far as using x-ray guidance and contrast, I haven't seen a lot of that happen, so I'm not sure I can give you a percentage there. Ben, does bone marrow concentrate already contain PRP. Bone marrow aspirate has platelets. So we always use platelet-rich plasma and platelet lysate in our bone marrow concentrate, usually 14 times. And those are derived from the bone marrow aspirate. So bone marrow has platelets in it, and bone marrow concentrate will have some platelets in it, but they won't be very concentrated like adding 14x PRP, which is what we will do. So the answer is bone marrow concentrate will contain a weak type PRP because you're concentrating some of those platelets as you're concentrating the nucleated cells. That also will depend on how you make it as to how concentrated that'll be. Or you can do what we do, which is to separate all the platelets, concentrate those, and add that back to the bone marrow concentrate. Judy, do you think donated placenta embryonic stem cells are useless because famous people have gone out to the country, Dr. Kong in California, having great results intravenously in the joint? Yeah, I'm not a big fan of Dr. Kong. You can see some of my my stuff on Chara Core, but this brings up, actually, I just talked to a patient about this, so this will be good. So let's go to PubMed. So that's U.S. National Library of Medicine. So here's the U.S. National Library of Medicine. This is where all of the medical journals index their stuff. And I'm going to pull up a paper that we published last year, which is this one. So this paper was published in the world's most prestigious orthopedic journal. So out of 71 major orthopedic journals, this is number 1 in the world, the American Journal of Sports Medicine, meaning it's got the highest impact factor. So it'd be the one that you would pick as being the New England Journal of Medicine of Orthopedics. And we actually looked at Dr. Kong's stem cell product here, Chara Core. We looked at lots of different products. Chara Core was one of them. Now, Dr. Kong was making the claim that Chara Core had lots and lots of mesenchymal stem cells in it that were live and young. At the end of the day, Chara Core, or none of the products that we tested, had any live stem cells in it at all. It was all dead tissue, nothing that survived to be able to culture. So Chara Core was one of those, and that's a Dr. Kong product. So as you might imagine, Dr. Kong, after we did this research, wasn't real on my A list because, you know, here's someone who had gone out and said that they were selling this type of stem cell product. I've got lots and lots of things that Kong has put out, but when it's actually tested by a major university, we did this with CSU and their Translational Medicine Institute, a new $55 million facility up there. There was no living mesenchymal stem cells in the product at all. So I don't know what kind of results she is or isn't getting. I can tell you that what she was advertising as being an umbilical cord Wharton's jelly stem cell product had no living stem cells at all, based on the research in the top orthopedic journal that we published with the CSU TMI just north of us here. Jeanette, can you please advise what information should be requested on a referral letter for a DMX? Instructions for the radiographer. My doc didn't know what to write for the radiologist. They won't proceed without that referral letter. I don't think specific instructions need to be given, meaning the DMX as it's taught has a very specific protocol that they follow. If you had to add anything in there, you might say, so it might look something like this. DMX-rule out CCI, obviously craniocervical instability. Please include all measurements. So there's a referral letter for you. So again, DMX-rule out CCI, please include all measurements. But there's a specific protocol that all DMX centers follow. Now, that doesn't mean that all DMX centers are doing a fantastic job at DMX. It just means that they're following the same protocol. So we would say that probably 2 and 3 DMX places we see are doing a pretty good job, good enough for us to get to a diagnosis. About 1 and 3 are kind of still using very old technology based on DVDs and aren't doing measurements, et cetera, et cetera. Pia, does the clinic in London treat instability, disc, C5, C6? Dr. Schultz mentioned my area needed treatment, but didn't mention what kind of treatment. I believe they do. You'll have to reach out to Dr. Kirkor about that one, but I believe they do. Yeah, Judy, I'm not going to keep going back and forth on this stuff. I don't look at celebrities or influencers as people I trust with my medical care. I know a lot of people on Facebook do, but I don't do that. Now, we've treated lots of celebrities. We've treated lots of football players, but I'm not here telling you who they are, because not only is that a HIPAA violation, but also that's not how we roll. So at the end of the day, I don't care who got treated where. So I'm not going to entertain all that craziness. Anya, thank you. So the pain relief in joints or discs is from the chemicals no longer being released. Does it work the same way for ligaments and muscles? Ligaments we can tighten and repair. They're easier to tighten and repair. So all fibrous tissue is generally easier to repair. So that would be tendons and ligaments. So it works differently for tendons and ligaments. But the goal of tightening those ligaments is to reduce instability, which then protects that joint. Anya, I heard from a person online that their facet hypertrophy got better after injections. Is the facet ligaments getting healthier? So Anya, is it possible? It's possible. It's just not reliable. So let me give you an example of that. See if I can find this. That's not always the easiest thing to do, but I'll give it a shot. And just guys, probably in the last 15 minutes here, just because we're getting a little past an hour, but happy to continue to answer questions here. Okay, here's one of my patients. So I don't think there's a video here. Let's get rid of that. Okay, so this is the C2-3 facet joint on the patient's left. This is an MRI. You can see on the patient's right, it should be that big, but it's now this big. Now that's probably the biggest C2-3 facet I've ever seen. This is a patient who was in a car accident, had C2-3 instability that was totally missed by the treating physician who didn't understand instability. So this joint just got totally destroyed over time. Probably 3 years before I saw this patient after the crash. And, so then we started treating the instability, and she went down to Cayman in order to get culture expanded cells placed into the ligaments and into that joint. And so let's see if I can get to one that's a good comparison here. I'm sorry, I'm kind of try to do a video here. Well, here's the post. So the post here shows a much, much smaller facet joint. So did that happen because of the culture expanded cells being put in the facet? Did that happen because we solved the instability issue? I can tell you that she's much better, but she's not perfect. But that joint got smaller. And so at the end of the day, it's possible to do. Is it reliable that we see, for instance, facets getting completely better and shrinking in size because they got completely better? Not a reliable finding. Now, what was different about this woman is that because this was traumatic, she still had a pretty good sized disc. So she didn't really have traditional degenerative instability. So that may have helped this along the way, whereas she didn't have a collapsed disc that was moving around too much. She still had a plump disc, and that was moving around too much because of a ligament injury, and she was still fairly young in her 40s when she got this treatment. So is it possible? Yes. Is it reliable? No. Francis, what's the significance of a lab being CGMP compliant? Does Signal A produce good cells? It could, yeah. So CGMP is good manufacturing, and it's current good manufacturing practices. It's a standard that would be used for something like a drug factory. Now, there's lots of levels of CGMP. You have to be a little careful there, because I've seen many labs call themselves CGMP because they might have a CGMP type air handling system, but CGMP is intense. So it goes beyond just the air handling. So for example, this is kind of a crazy example. Let's say that you're using antiseptics to clean within the lab. Now, you would think that if you have an FDA-approved antiseptic that's supposed to, let's say, clean steel, and you're cleaning a steel hood, that you're good, right? Not in CGMP land. In CGMP land, you have to do what's called a coupon study. So you have to actually take a piece of that steel. You have to use that FDA-approved, already FDA-approved antiseptic on that coupon. Then you've got to measure the bacterial growth on that and submit that to the agency. So CGMP compliant versus CGMP is different. CGMP compliant might just mean that the air handler is CGMP, like we have in our lab in Colorado. But CGMP, they're following that standard. They're being expected to that standard is a completely different deal. Let me give you a second example that's even crazier. So we buy medical gases, right? Those medical gases are certified to be sterile. Those medical gases only can come under prescription from medical gas houses that do this stuff all day, every day. But in a CGMP, and in the most sterile OR in the world, they'd be accepted as fine. But in a CGMP lab, you'd have to test each batch of those gases to make sure it didn't harbor any bacteria, despite the fact that it's already certified not to. And then you'd have to test all of the lines that go from that bottle to where it's being used. So again, it's a completely different world in a CGMP lab that's being inspected to be CGMP. And the reason it's like that is those CGMP labs are designed to make lots of drugs at scale. So if you have a breach of sterility at some point, you might have 1 million doses that get shipped that are contaminated. So the stakes are up much, much higher than in an operating room, right? If a mistake on sterility is made in an operating room, it affects one patient or maybe a dozen patients before it gets caught. If it's in a CGMP Pfizer drug factory, maybe 1 million doses go out and no one knows they have bacteria in them. So CGMP compliant doesn't necessarily mean that it's a CGMP certified lab. Deanna, how would you know if P2G harmed your nerves, new headaches, nausea, pain, and jaw? It would be a nerve injury usually that occurred during the procedure. So what that would mean is, for example, you're getting injected and all of a sudden you feel a zinger go down your arm into your thumb. That's the C6 nerve in the neck. And then after the procedure over that next 2 weeks, your thumb becomes numb and you start to get some atrophy in here. You could reasonably assume, or at least have a high suspicion, that there may be a C6 P2G caused nerve injury. That's an example. Anya would say Prolo is more dangerous than PRP or stem cells because it can cause nerve damage. You definitely need to be more careful with it, for sure. You need to make sure you're not getting it around things like spinal nerves. So it's definitely something that you'd have to have a higher, a lower risk tolerance with in those types of scenarios. Judy, do you recommend PRP or A2M for moderate hip osteoarthritis? Judy, we have much more data on PRP by a factor of 100 to 1,000. Well, maybe not 1,000. Let's say 100 relative to A2M. So just so that everyone understands what Judy's talking about, A2M or alpha-2 macroglobulin is something that lives in your serum or your plasma, and it's considered anti-inflammatory in that it blocks one of the inflammatory molecules. So we have used A2M as a preventative. Now, we don't really use A2M as a treatment by itself, and we'll always add it to PRP. It's also very syrupy, so getting it through a small needle is difficult. So it actually helps to add in PRP because it thins it out. So it allows you to use much smaller needles on the patient. Now, A2M isn't really a product, so to speak, other than there's a couple bedside centrifuges type systems that can concentrate it a bit. We also can concentrate it in our lab, but you're not getting pure A2M in there. You're getting A2M plus a bunch of other stuff. So A2M is a natural anti-inflammatory molecule. I think it's good for prevention. As far as treatment, we have much more data on PRP. So I would think that's the way you'd want to go. But if you're going to want to use A2M, you can just add it into PRP and use both. Liam, when I push the back of my skull at the base and I do a chin tuck, my head pain dissipates and I feel very normal. Any idea what this means? Yeah, so Liam, that's interesting. So if you're directly in the middle, one of the things that you could be doing is to help the rectus capitis posterior minor. Let's see. Okay, so rectus capitis posterior minor here. So rectus capitis posterior minor is at the very back of the skull here, kind of off to, well, actually that's major. The minor is in the middle. So the colored one here is rectus capitis posterior major. Rectus capitis posterior minor is the one right in the middle there. And that rectus capitis posterior minor hooks into the dura, or the covering of the brain. And because it jacks into the dura, it's believed one of its functions is to open the dura there when you're in extension. So if you're in flexion, you're putting some pulling on that. And if you're putting pressure on it, it may allow that muscle to function better. Now, that's one possibility. You also could be putting pressure on the greater occipital nerve. That's off to the side. That can also sort of block the nerve and help the headache. If it was transverse ligament, you'd be going into the problem, meaning that when you're flexing like that, you're putting pressure on the transverse ligament. That's going to move that dens potentially into the dura and spinal cord. So it's probably going to piss things off. So flexion would not be transverse ligament. That'd be more extension, meaning extension is better with transverse ligament. Flexion is worse. But you may be dealing with or helping that rectus capitis posterior minor muscle. Sure, Deanna. And Anya, thank you. So injecting muscles and ligaments with Prolo isn't dangerous if it isn't close to spinal nerves, meaning other nerves aren't in danger of damage. Yeah, Anya, you just need to be a little more careful trying to stay away from big nerves with Prolo. And it's mostly spinal nerves that we're concerned about with Prolo. So it's not dangerous if it's done correctly. No, it's a fairly safe treatment. But like anything else, right? Any treatments we have, I mean, here's a good one for you, and it's hard to believe this is true, but this is based on a study done in 2014 that taking Motrin for 90 days or more has a 1 in 1,200 mortality rate, meaning 1 in 1,200 people who take Motrin for 90 days or more end up dying due to a GI bleed. So everything is potentially dangerous, including stuff you can buy at the grocery store is the example there. There's a YouTuber who had their C1, C2 overhang treated with only C1, C2 facet capsule injections, 7 to 8 millimeters down to 3 to 4, confirmed in her DMX report. I thought you said that capsule is not important. I'm not quite sure what it is we're discussing here, meaning intra-articular facet or just into the capsule. So I think we've discussed this. Capsule really means I have no idea how to get into the facet joint, so I'm putting the needle somewhere in that vicinity. It doesn't mean that they actually injected or documented that they injected the facet capsule. So I think what you're talking about is someone who had, in all likelihood, let's say a dozen, maybe PRP or Prolo injections in and around all of these ligaments up here. Now, one of the problems with the place I think you're talking about is I just, as another patient from this morning, I did 4 telemedicines this morning in potential PICL patients. And one of them now needs DMX repeated because she was told that her overhang was better. But when I looked at the second overhang, so for the first overhang, this is her head, and her head goes way over around 50 degrees. But for the second one that presumably showed improvement, her head went over only about that far to, let's say, 30 degrees. Same thing. She would go from 7 to 8 millimeters to 3 to 4 because the DMX was never repeated at the same angle. So I'm requiring her to get another DMX that's repeated at that 50-degree angle so we can see where she is right now. And that's something I've seen quite a bit out there. So perhaps that's what you saw. Perhaps, doing a dozen Prolo injections kind of randomly in that area was able to tighten down the transverse or intertransverse ligament and or AO ligament, or perhaps it never really happened. So hard to say, but I can tell you we've done more Prolo in that area and PRP than I can count, and never saw substantial changes in DMX when they were properly performed. Does it mean it's impossible? No, nothing's impossible. Everything is possible. Duck Pede, do all of your fellows learn C0, C1, and C1, C2 facet injections? Not all. So a lot of what our fellows learn depend on where they start. And what I mean by where they start is and how quickly they learn. So I'm going to give a shout out to Dr. Pitts, for example. Dr. Pitts came in from Emory in Atlanta. He'd already had great hands-on spinal injection experience. So he had started a little bit more advanced than some of the other fellows. And he was also incredibly adept at picking things up when it came to procedures. So heck, by the time we were 5 months in and he was rotating with me, there wasn't a lot I was doing for him. I was maybe showing him some more advanced things. But at the end of the day, I was back there twiddling my thumbs as he did his cases, because he was that adept at picking things up quickly in that 3-dimensional world of how you perform injections under imaging guidance. Having said that, and I'm not going to name any names, we can go the other side of that, where someone comes in not so with less experience under their belt, and they're just not as good or quick as picking that up. Now, they'll get it by the end of the year, and they'll be quite competent. And by the end of the year, I'll have them injecting me because I'm very confident that they can do this stuff independently without someone looking over their shoulder. Now, Dr. Pitt's example and the fellows like that are going to get into more advanced things like 0-1 and 1-2 facets and be very comfortable with those, or at least as comfortable as you can be, meaning that none of them are going to have 1,000 0-1s under their belt or even 100 0-1s under their belt, but they'll have enough where they know how to do it. They feel comfortable. They're not going to hurt anybody. And they can competently perform the procedure and continue to learn as they see more patients. Whereas the other example, they're not going to get there during a fellowship unless they stayed for another year. So that's how that all works. Duck Pete, thank you. Judy, generally PRP doesn't work for moderate hip arthritis. That's going to be more bone marrow concentrate or a stem cell type procedure, or a procedure that has stem cells in it. So moderate hip arthritis is not going to work that well with PRP. Now, if it was moderate knee arthritis, that would generally respond more reliably to PRP. So moderate hip arthritis is going to be less responsive to PRP. Mild hip arthritis will be responsive to PRP. Severe knee arthritis will not be that responsive to PRP. And then it all depends on what kind of PRP, right? Are we talking about leukocyte rich? Are we talking about leukocyte poor? What concentration is that PRP? How old is this patient? So for example, if we're talking about mild to moderate hip arthritis, we are trying to see if PRP will work, because if it's moderate, it's not going to work that great for hip arthritis. But let's say it's mild to moderate and they're right on the cusp, and we've got a 45-year-old patient, well, let's say 50 years old to make it easy. We'd want to do leukocyte poor PRP, and we'd want it at least to be 10 to 15 times concentrated over baseline. Problem is, there's not that many machines on the market that can get there. You generally need a lab to get to, example, 15 times over baseline, for example. So much more complex calculus than just PRP and moderate hip arthritis. Okay, guys, I am out of questions, and I am about out of steam for the day. Long week here of seeing patients. Let's see, I got one that just came in. Duck P, for suboccipital muscle atrophy, how would laser tracking exercises make those muscles bigger? Isn't neuromuscular control strengthening different from true hypertrophy atrophied muscles? So Duck P, what you're talking about there is you first lose the neuromuscular control, and then over time, the muscle atrophies or gets smaller. And it goes the other way too. If you're building muscle, you'll first gain neuromuscular control, and then the muscle atrophies. So if you go and hit the gym, for example, and you haven't lifted in 10 years, you're not going to get much bigger in that first 3 or 4 weeks, because it's all about that first 3 weeks connecting the nerve to the muscle. You might look more toned, but you're not going to get bigger. If you want to get bigger or hypertrophy, you got to go beyond that as far as time is concerned. Same thing for atrophy, but in reverse. So for getting those muscles bigger, the first month, not going to change much. After that, you can get those muscles bigger over time, assuming you don't have anything else you're pissing off when you're doing that. And that means you've got to get rid of the instability, etc. Okay, guys, so thanks so much for spending the time. I think I will be here on Monday. In addition to that, today's focus was on how we get to a CCI diagnosis. So if you came late, make sure you watch that, because I really want patients to understand how it is we do that. And we're at 2.5 hours or 1.5 hours today. So we're getting on the longer side here. So thank you for your interest. And I should be here this coming Monday as well. So everyone have a wonderful weekend out there. Thank you very much.